last November, the U.S. Census Bureau surveyed Americans regarding their mental health. They learned that 55% of Americans reported feeling sad, depressed, or hopeless, 55% several days a week, and 23% felt that way more than half the time. Even pre-COVID, 17 million Americans suffered from depression. Hello, my name is Dr. David Palmiter. I'm a professor of psychology and counseling here at Marywood University, and today's edition of Mental Health Matters regards depression, suicide, and a screening event we're going to hold here on campus on October 7th. I'd like to begin the discussion by introducing my panel. To my immediate left is Dr. Matthew Schaefer. Dr. Schaefer is the director of our Psychological Services Center here at Marywood that will be hosting our screening event. Next to Dr. Schaefer is Dr. Lauren Hazuri. Dr. Lauren Hazuri is a nationally known speaker and also has a private practice in Scranton. Next to Dr. Hazuri is Dr. Bradley Janey, who's a full professor of psychology and counseling here at Marywood. I've been there, done that kind of guy. And finally, at the very end, is undergraduate student Evan Cobb, who also serves as co-producer for this program. Welcome, everybody.
Thank you.
So let's just begin. How would you differentiate, let's say, major depression from someone having a transient mood problem, just having a bad week or whatever?
Well, I would say probably duration and intensity are probably two features. Something that lasts longer than maybe 2 weeks at the outside, maybe a little bit longer than that. Mm-hmm. And there's no identifiable cause. I think that's how I would characterize it.
Mm-hmm.
Yeah, I think that identifiable cause part is usually what I first look for. And also, I think when somebody has a difficult time with following through and doing the things that they used to really like to do, and now they just maybe even don't feel like doing it, or if they want to be able to do it, they just don't have the like the energy and the wherewithal to do that and meet their goals.
Mm-hmm. Mm-hmm.
And that's, we touched on it, but the key is that they're not able to perform their normative tasks, right? They're not enjoying the things that they used to. They're not able to activate and fulfill those responsibilities. And I know when we trained, we talked about this less now, but reactive versus organic sort of depression. Certainly anything can happen in our life, and I believe this wholeheartedly, that would influence us to move towards a depressive episode, right? So pain plus isolation is really the recipe for disaster when it comes to a major depressive episode.
So you guys have started to talk about some of the symptoms, you know, not enjoying things. What are some of the other central symptoms of depression?
I look for changes in lifestyle, meaning, you know, maybe somebody's eating more than they typically would, or eating a lot less than they typically would, sleeping more, sleeping less. I find a lot of times with my high school and college age kids that are struggling with depression, they just really can't, you know, get out of bed, or they say, you know what, you know, I used to be able to get up and do my homework and get on with my day, and now I'm just like sleeping through my alarm, and then they, you know, end up not doing what they wanted to do or taking care of their responsibilities, and then end up feeling badly about themselves, and it turns into a vicious cycle.
Mm-hmm.
Mm-hmm. You know, maybe they're using substances more so than they were before. You know, things like alcohol or some of the other things that are out there. They have started using those substances with more frequency, and they are worrying about it more, and it kind of can create a vicious cycle with that.
So sometimes people who know someone who's depressed, let's take a college student has a friend who's depressed, and they invite them to do something fun thinking this will lift their mood, and they're surprised when the depressed person is inclined to decline that offer. Mm-hmm. What do you think's going on there when that happens?
It's that amotivational component, right? It's very difficult, even for enjoyable activities, to activate and to motivate yourself to go and engage in those things. I think it's important to note too, especially for male youth, young adult and teenagers, this can manifest as an agitation. So you see conduct problems, behavior problems.
Mm-hmm. Mm-hmm. Evan, you've put together some numbers on how common depression is. Care to share a little of that?
Yeah, sure. So pre-pandemic, major depression major depression with severe impairment has affected 11 million Americans, and that's at least 4.5%. And 35% of those adults did not seek treatment. So that's, like we said about the motivation, that's a big deal. And I believe that kind of points to the stigma around getting therapy, because a lot of people think, oh, something's really wrong with me because I might not know what it is exactly, but if I seek out treatment, then I admit that I'm weak. And a lot of people in this society don't want to admit that they're weak. And I think that's definitely a cultural aspect.
So then depression, when it gets really bad, makes people think about suicide, which for folks that haven't experienced suicidal feelings is mysterious. Can you help our viewers understand how depression can facilitate someone thinking that way and thinking that that makes sense to do?
Well, I think, you know, what I see a lot of times with the clients that I see, it's that the pain gets so overwhelming. And maybe sometimes if somebody hasn't sought therapy or hasn't talked about this with somebody, even a family or friend. So if somebody is just in isolation and pain, like you mentioned before, and they don't see any real coping skills or don't have any coping skills that they can use, it's just they're looking for a way to not feel this pain anymore. And so then they have what we call suicidal ideation a lot of times, where maybe they don't have a plan or intent to act, but they just think things more like, you know, oh, I just wish I wasn't here anymore, or I just wish this would be over. I don't want to feel this way anymore. I wish I wasn't born, things like that. And I do find that throughout the pandemic, at least with the clients that I'm seeing, I've seen a lot more suicidal ideation than I had in the past. Not necessarily more plan or intent, but more ideation, because, you know, a lot of times, not only are people experiencing loss in a way that we haven't before, loss of loved ones, loss of jobs, things like that, loss of their social life and their friends and doing the things that they used to really enjoy that would pick up their mood. But, you know, when they're home alone, they don't really have the coping skills. They don't have the opportunity to do things that make them feel like them. So they forget all the things that make life worth living. So I think, you know, what I always try to do is reintroduce them to themselves. Because it's not even that they don't want to be here anymore. They don't know how to be here anymore.
Yeah, well said. And I think if we think of depression as a continuum, and you got depression over here and mania here on the far end, the total depression isn't suicidality. That's laying in bed and it's purely vegetative kind of issues. It's when someone may start to feel a little bit better that they'd actually paradoxically be at more risk for a suicide attempt, right? Because pure depression, you don't have enough motivation to follow through with things. You may still have the hopelessness and the suicidal ideation, but it's too much work to activate to even engage in the planning. And so someone who's very depressed, who may start to look to be improving and may start to activate a little bit, may be more at risk for suicide than they were previously. And depression is episodic, so these major depressive episodes don't last forever. And it's sometimes when people look better is when they're most at risk.
Yeah, so, you know, if depression was almost like an alien, one of science fiction, infecting the body, it says to its host, everything sucks, it's your fault, and it can't be changed. And that's very painful, as you guys are talking about. Evan, you have some numbers on suicide in America?
Yeah, so suicide is actually the 10th leading cause of death in the U.S., and it's the second leading cause in individuals aged 10 to 34, which is kind of alarming in itself. It's the fourth leading cause in ages 35 to 44. And nearly 12% of adults 18 to 25 have had serious suicidal thoughts.
So I've met before in communities where there have been several teenage suicides, and parents join because they're hoping their teen won't be the next one, and they say some of the same things. How could so-and-so have killed himself? He was captain of the football team, good looking, everybody loved him. Can you help people understand how those external variables often don't tell you much about suicide risk?
If, one of the things that I have read about in regards to this is, depression, suicidal ideation. At the core of it is very strong negative self-evaluation, and there's just a real dissatisfaction with who, there's a big difference between who they think they are and what they think they should be, and that's kind of a key aspect of this.
So, Dr. Janey, you already started talking about this other problem, other conditions that sometimes coexist with depression. You mentioned substance abuse. What are some other common co-occurring problems that travel with depression?
So I think, the top couple that I typically see is, kind of like Dr. Janey just alluded to, is like low self-esteem. So self-esteem, somebody like you were describing, the captain of the football team, somebody who's good looking, they might have high levels of confidence, which is like confidence in your abilities or your qualities, but self-esteem is confidence in your own value. And those two things are quite different. And so somebody who is, who has a lot of friends and has a lot of talents, also can have very low self-esteem. Also anxiety. So anxiety and depression are kind of like, I would say they're like bacon and eggs, spaghetti and meatballs, where there's one, there's often the other. And so, because anxiety can typically, cause that isolation. Maybe if somebody has social anxiety, so they don't socialize with their peers, and so then they're home and they're isolated, and then comes that pain, and then comes the depression.
Well said. And I think with those high-achieving people, if we look at ultra-high-achieving people, right, like Deion Sanders comes to mind, wins the Super Bowl, height of his profession, and has a suicide attempt later that evening. It's very common. There's been many gold medal athletes at the Olympics. They earn the gold medal and then have an attempt. I think it's that irrational belief, I'll be happy when fill in the blank, and then that event happens. And these guys are at the pinnacle, these guys and these women are at the pinnacle of their craft, and they don't feel better. And then paradoxically they're at risk, right? Also, and exactly, anxiety and substance misuse are highly correlated, and also eating disorders, right? You see a lot of co-occurring depression in those populations.
What do you think of the cultural messaging that suggests if someone's feeling depressed, like, come on, suck it up, walk it off, be a man, be tough, whatever, that kind of messaging to people who are depressed?
So I often think, I think about it as being like a brain game a lot of the time. So even with the minor lifestyle changes that we can make with, sleeping, the right amount of sleep for, high school, college age, that might be 8 to 10 hours, which none of them get. Eating 3 meals and 2 snacks, exercising to increase that serotonin. Serotonin is a neurotransmitter, which is a chemical in our brain that makes us feel good. So like just changing lifestyle. So like with each lifestyle change, we can really change our brain chemistry. So it's not something that you can like put your chin up. You have to make some changes in your lifestyle, in your behaviors, in order to change that brain chemistry so that you can feel better.
All right, so maybe that's a nice segue into what we try to do about it. I think those of us who are practicing clinicians are often frustrated by the gap between how many people could benefit from care and how few people get care. Even in that U.S. Bureau census I just mentioned, more Americans were taking medication than were receiving counseling. Only about 30% were receiving counseling. So can you describe for our viewers, I guess it's a two-part question, and you can each take different parts if you want, but what are the treatments that work, and how do they look like? How confident do you feel when you're delivering them for depression?
Well, cognitive behavioral therapy, changing the way that you think, that has shown pretty consistent results in terms of clinical trials. And the presumption is behind these kinds of interventions is by changing the way that you think, that is going to impact the way that you feel. It's going to impact the way that you behave. And so learning to think like that can be enormously beneficial to clients that are struggling with this. It takes a while to really, it's a process where you're trying to reorient a client about the way that they're thinking about themselves and about the world, and kind of question some of the thinking patterns that they have developed naturally over, the course of their lives.
And for people that are experiencing suicidal ideation or have suicide attempts or engaged in self-injurious behavior, dialectical behavior therapy is really the gold standard. And not just the skills, but that's a combination of ongoing group and individual therapy with a real emphasis on hard skills, coping strategies to manage that dysregulation that one experiences so that they can remain safe.
So which is kind of like the cognitive behavioral therapy Dr. Jane just mentioned, plus meditation type of and mindfulness type of strategies.
Yeah.
So they're very similar.
Yeah, and multiple coping skill strategies. And the theory that I really appreciate is that it's not the individual that fails if they do experience ideation, or they do experience an attempt, or they do self-injure. It's that the coping skills failed, and doubling down and establishing those coping strategies so they're able to handle the next adversity.
So someone comes to you depressed, and assuming they do the things that you teach them, how confident do you feel as a clinician that it's going to be transformative for them, the work?
Oh, I feel absolutely confident. A lot of times I think that's why people do opt for medication sometimes without seeking therapy, because they just don't have the energy and they're worried that it's not going to work. But I can say that, not only the research states, but also in my experience as a clinician, cognitive behavioral therapy, dialectical behavioral therapy, these are evidence-based treatments that are proven to work if you work them. So I think that support in the solution is really important. So a lot of times if I'm seeing high school or college age kids, their families will be very supportive and try to, hold them accountable and keep them in check and things like that. With adults, maybe their spouse or their loved ones will help, because this is really, it needs to be an effort for you with, with your loved ones, with the support system. That's when it works best.
Absolutely. Beck Institute, which is a very famous CBT site, they had taken a look. They wanted to find out what was working within their therapies, and the largest impact, far and away, was follow through with homework. The people that did their homework got better, and the ones that didn't. Now, it's granted that does take a lot of motivation outside of treatment, but you're only in treatment really if you're going once a week. That's 6 days and 23 hours that you're by yourself. So applying and following through with these things is so critical. And as was stated, well, if you can be reinforced within your support system and have a support and accountability system, so you're held accountable for the times that you're not following through with things and reinforced when you are, that's really a recipe for success.
What about kids who seem sad or depressed? Are these treatments available to them?
So is it available to children? Oh yeah, cognitive behavioral therapy works great with kids. And it's kind of fun to make it fun for them to learn. So one thing that I find really works with kids is when they're trying to identify those negative thoughts. We call it like a negative thought voice, and let's name the negative thought voice. So I remember when I was doing this with my own daughter when she was little. She named her negative thought voice Harry Scary, and she'd say, "Harry Scary told me that you're not going to pick me up at school today," or whatever. I said, "Oh, that Harry Scary," and oftentimes. When you're doing it with kids, it just then becomes a part of, they can look at their thinking objectively, and if you start young, it's great because we all can use these tools. It doesn't necessarily have to be somebody who is struggling with a clinical depression. We all have subclinical times, throughout our lives, and so learning these strategies and skill sets as a young child is really beneficial for everybody.
And then some clinicians who do the interventions you guys are talking about will add interventions from positive psychology as well. Can you tell our viewers what that is?
It's a kind of one task that's associated with it that's very common is kind of doing an inventory in one's life and finding things to be thankful for. It's, like one of the things that our parents taught us growing up is count your blessings. And actually there is a lot of wisdom to that, being grateful for the things that you have. That if you're able to do that consistently, one day after another for an extended period of time, that is going to start taking hold and it's going to start having an effect. It is just something that you can't let it slide in order for it to really start having the kind of effect that we're looking for. You do it once or twice, that's not enough.
Absolutely, and for me, it's the big three. And I had a loss in my life, and you reached out to me to make sure that it's okay, like a good friend does. And ground yourself in the big three. Opportunity for 7. Give yourself that chance for 7 hours of sleep. Engage in physical exercise. Hit the gym, and surround yourself with positive social support. If you can do those big three, and ground yourself there, and no matter what you do today, you're going to do those big three. That's super important.
So October 7th, Thursday, October 7th, here at the Psychological Services Center, we're going to be hosting a site for National Depression Screening Day. What's involved if people decide to take a part of that?
So people can come into the clinic and they'll be greeted by student therapists at the desk. They'll be provided with a brief screener. It takes about 5 minutes to fill out. Another student therapist will score that for you, go over your results. If there's a positive finding, it's depression and it's a bipolar screener, there's a trauma screener, that's all one document. If there's a positive finding in any area, the person is offered a referral. If they're a student, they're sent to the Student Counseling Center. If they're in the community, they could be referred to the PSC, and they can be set up an appointment with that day. We're on a sliding scale, so the average person pays $5 that comes for services. Some people pay nothing. If people are on Medicaid, there's no payment for services through the PSC.
What's the cost for the screening day?
$0. It's a public service.
Do people need to provide any identifying information?
Nope.
It's anonymous.
It's anonymous. Of course, you will see the student that will interact with you, and they'll be able to interact with you in that way. But yeah, no social security number, no name. It's just a public service.
Just given a number when you come in.
Yeah, you're given a number and a color on a popsicle stick.
How long should people allow if they want to come? How long does it take?
For the screening? Yeah, it's about 5 minutes to fill out, and then the discussion with the students. It would depend on whether or not you have a positive finding, but within 15 minutes, people would be on their way.
Is it true that the person coming in determines how involved that discussion gets?
Absolutely. Absolutely. And of course, even if someone has a positive screening, it's not mandatory that you're set up with services. It's just offered to you.
So what if someone watching has someone they care about who they think would be good to come to this? Do you have any suggestions for how they might approach them about encouraging participation?
I think one thing that I might tell a friend is that I would go with them, and I would pick them up and I would bring them to the depression screening day. I think a lot of times people are afraid of getting a diagnosis. They're afraid of that label. Oftentimes parents are afraid that their children are going to have that label. I remember one time early on in my career when a parent, I showed them the different rating scales and what the diagnosis was, and they said, well, do we have to tell her? And I said, well, I think she knows, I think she knows. And so, if friends are kind of a little bit worried to call a friend and say, hey, listen, maybe this depression screening day is a good idea for you. They already know, so don't be afraid that you're going to alert them that they're depressed or that you might think they might be. Getting into the solution is a really easy way to do that, and just taking the next right step. So I think if you're a friend, call your friend, make the suggestion, pick them up, go with them, offer that social support,
and do the screening yourself.
Totally.
Why not? Yeah. So each of you can share a final thought for everybody, anything that you'd like that you think could be helpful.
I would say get outside, get some sunshine, get some exercise. According to the research, exercise, regular exercise and being outside can be as effective as something like, the Zoloft, one of the common medications that's associated with treatment of depression. So people that get outside and get their body moving has an enormous benefit that I think not everybody appreciates the effectiveness of it. They underestimate it, and they shouldn't.
Thank you.
Yeah, and just to kind of piggyback on what you were saying, the exercise and also the sleep and eating nutritiously so you can fuel your brain and your body. Those three lifestyle, you talked about your 3 pillars, these are my 3 pillars, eat, sleep, exercise, because it can really increase your baseline. Oftentimes between my intake and our first therapy session, I'll say, hey, why don't we try to manipulate these lifestyle patterns? Maybe we could even increase baseline before we begin. Wouldn't that be cool? And we often do it. So that's my suggestion, those 3 things.
Yeah, I was thinking a lot about stigma since you had asked the question, and it came up a couple of times. It's that I fundamentally believe that if someone is experiencing symptomology, I would be in the same place if I had the same biology and the same life experience that any one of us would be, and normalizing that. And we can see that very easily through like an extreme thought experiment, right? So besides Evan, we're all middle-aged individuals. If we were diagnosed today with early onset Alzheimer's and we were going to be a burden to our family for the next 30 years, it's irrational to think that we wouldn't be contemplating suicide or experiencing a depressive episode. That's just one key example, and if that's true, then all of those other dynamics are. We're all just creatures of our biology and our life experience, and that normalizes. And it's a lot. If we fundamentally accept that, it's almost impossible to other.
I would say unplug, honestly. I think a big reason for depression nowadays, especially in younger crowds, is because people are plugged in and they're seeing all these images, especially sexualized images, and they build up these expectations for what they're supposed to be, and it doesn't, I think deep down, almost on a spiritual level, they realize that this isn't it, and so they start seeing all these symptoms and they don't necessarily know what's going on, especially at a young, naive stage in their life when they're kind of building their identities. So get outside and turn off the TV.
Unplug. Thank you. So I'm going to give you a phone number that you can call if you want to inquire more about the screening day here at Marywood. That's 570-348-6269. Thank you for watching today. I want to thank my guests and my co-producer Evan for helping me out. Please tune in next month when our topic will be COVID coping, top strategies for doing well in this time of international crisis. Well, that's it for now. Thank you for watching, and remember, mental health matters.